Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case of a 25-year-old female who came to our ER with history of superficial burns over the back due to hot water fall at home. Sir, on initial 10-second assessment, the patient was conscious and oriented. And coming to the airway was patent and there was no secretions, and the facial area was not having any burns. And C-spine was appearing normal. In the breathing but air entry was bilaterally equal with respiratory rate of 22 per minute with saturation of 100% in room air. And in circulation, her BP was 110/80 with pulse rate of 98 per minute with all peripheral pulses palpable, and her pain score was 7 out of 10. We have put 2 large bore IV cannulas and she was given fentanyl 30 microgram. And further disability wise, her GCS was full score with pupil bilaterally reacting. In exposure wise, here we exposed the whole patient, and her history is like she was pouring hot water from a kettle, and the kettle got misplaced and fell over her back. And in the local examination, she was having dermoepidermal burns involving the right side of the body, that is superficial second degree burns, sir. And it was over the right half of the back, right half of front of abdomen, then entire right hip, right and thigh with right buttocks. There, and also there was back of right arm upper 1/3 was also involved. The skin peeling was noted over the dorsal aspect of upper arm, right back and right thigh. Then there was redness and blackish discoloration noted, sir.
Percentage of burns?
So total here we calculated according to the palm rule, and we got nearly 15% total percentage of burns.
Okay.
So further, as initial pain management was done, and also we removed the clothings from the burned area, and also we removed jewelries on the neck region. So further we have put 2 IV large bore cannulas, and we started IV fluid for the patient. So we did with the Parkland formula, that is 4 into total burned surface area into weight of the patient. Supposedly the patient's weight was 50 kg, sir. So total it went up to 3000 ml. So initially we gave the 1500 within the first 8 hours, and the rest within the next 16 hours, sir.
Okay. So we have got a young lady who has come with a 15-degree burns. It is due to the hot water. So that is the basic history. So what are the different types of burns that you can anticipate in a patient coming to the emergency room? This is like hot water. It's a liquid related. Then you can have, what are the other types?
Thermal burns, which will have the liquid or the fluid liquid, or it can have like sunburns, or else flame burns can be there. Then
so I'm giving you a history. I'm just assuming that you have got a patient who has come to the ED. You can get in history, he was maybe cooking something in his kettle, and suddenly the kettle got blasted, and he had some minimal burns over the neck, maybe 2%, 3%, and he has been brought to the emergency room. And I am giving another scenario where the same lady has come with 15% of burns. The same lady with 15% of burns. So what are the major differences in these 2 categories of patients?
So the first case where there was a blast injury, the patient can have associated other problems due to the blast itself, including trauma to the chest or abdomen, and also the neck area was involved. So patient can have airway compromise also. Okay.
So what differences you will make in your assessment? What all additional things that you will assess in that patient? You said regarding trauma, I agreed to that. And what are the other things that you need to think of? Suppose the same patient has been brought, there is no external injury. He has been evacuated from the area and he is unconscious.
So patient can have carbon monoxide inhalation, which can cause the unconscious state of the patient. So patient need high flow 100% NRBM or high flow oxygen, or hyperbaric oxygen therapy should be started, sir.
Okay, so again we'll come back to the same patient. He was conscious oriented, but he is having hoarseness of voice.
That
So what
means
will
the
you do
airway
next?
will be compromised. So we'll have to intubate the patient. Airway should be secured, sir.
So what all precautions you will take for intubating that patient?
So the main thing is that as if the patient is having a burns injury, so we'll have to look for any how's the airway is the patient. The lip or the oral face of the patient can be like swollen, then tongue can be swollen, or also vocal cords as well as the larynx pharynx can be swollen. So the chance of normal tube, normally if you are using as 8 or 7.5 tube, it may or may not can be used for intubation. So
It
we'll
will not
have
be
to
suitable. It will not pass. It might not pass through your vocal cords.
So we'll have
Smaller size tube.
tubes
Then,
given.
so what are the signs that you will again take that this patient has possibly gotten inhalational burns? I am not saying airway burns, inhalational burns.
So like patient can carbonaceous sputum can be there. Then singeing of the hair can be there. Also, patient can have wheezing or hoarseness of voice.
Also, these are all important things, and here the concern is that we don't want a respiratory compromise to happen to intubate the patient. So that is the key difference. So whenever you wanted to intubate a patient in an airway burn, there are having challenges. So here, as you said, the challenges agreed. But the most important thing, don't wait for an airway compromise to happen. You have to anticipate that this patient might go into an airway compromise. So later on, when you are planning to intubate because of the vocal cord edema and all, you might not be able to intubate at all the patient. So you need that time to do a surgical airway. So already if the patient has come with an probably airway compromise like hoarseness of voice and all, it's always better to go ahead and secure the airway as early as possible. And other challenges, maybe the burns have gone inside. There can be a lot of bleeding from the mucosal area and all. So that can be a different challenge. But the most important thing, as you said, you have to treat any burn patient, not this patient what we are discussing, what any burn patient like a trauma patient, like blast injury and all can happen. So think about the cervical spine injury, protecting the cervical spine, and most importantly, airway burns. As an ED physician, that is our priority, to make sure that there is no airway burns. If at all we are suspecting an inhalation injury or airway burn, secure the airway as early as possible, and always keep in your mind a possibility of carbon monoxide poisoning. So the worst scenario is what I have said, unconscious. So what could be the normal presentation? What could be the patient is complaining with after getting evacuated from the area? What will be the common symptoms that they might be complaining when you are suspecting a carbon monoxide poisoning?
The patient can come with a respiratory distress, or patient slightly untied.
There will be headache. That will be the most common presentation that you need to think of. They will be having headache, irritability, and all those things will be the most complaint. Then respiratory distress, depending upon where the airway burns have occurred and all. But usually when you look into the carbon monoxide poisoning assay, the cherry red spot in the retina and all those things can be present. But routine, what we need to understand is that they will come with headache. Just imagine that you are going to a smoke, and suddenly what will happen, you will feel a lot of carbon monoxide you will inhale, and as a result you will have some discomfort to the chest, and mostly you will have headache. So when you are suspecting something, some patient rescued from burns, thinking of this thing, even if the saturation is looking normal, it is always advisable. You have to think of carbon monoxide toxicity. You have a co-oximetry, you can well know what is the carbon monoxide level, and start oxygen and maybe hyperbaric oxygen therapy. Okay. Now coming to this patient where we had a thermal burn with water, and you started deciding on Parkland's formula. So my question, whom all you will start with fluid resuscitation? Whether all patients with burns needed a fluid resuscitation as per Parkland formula, or where you wanted to use it?
So for adult patients, the Parkland formula can be applied in case where 15 to 20% or greater than burns are there.
Maybe about 10% we can safely say, about 10% you apply Parkland formula, but less than 10% or maybe 15% up to we can wait. But it all depends upon the body surface area. Even if it is an adult, it's a small adult patient. If it is like 15% or 13%, we definitely need to give fluid replacement. So 10% above definitely, and pediatric age groups?
Less than 10 in pediatric ages as well as in old age also.
You have to be a little bit more aggressive, like above 5% around, you can start fluid resuscitation as per Parkland formula. Now coming to the Parkland formula as such, what is modified Parkland formula? What are the differences? What is the present recommendation of modified Parkland formula?
2 to 3 ml per kg.
Okay, so every patient doesn't need a 4 ml per kg except One condition you need to go still 4 ml per kg. This type of burns you need to continue 4 ml per kg. Rest all burns you can give 2 to 3 ml per kg. This aggressive fluid resuscitation like 4 ml is not needed except for electrocution. If it is an electrocution, electrical burns, you need to go ahead with 4 ml per kg, where we are thinking more in terms of rhabdos also. So 4 ml per kg is for electrical burns. For the rest others, you can go with 2 to 3 ml per kg, or maybe mid between. In pediatric age group also you can go for 3 ml per kg. So whatever the fluid that you are calculating, half of it you need to give over the first 8 hours and rest over the next 16 hours. And fluid, what you will select the fluid of choice?
Ringer lactate.
It is ringer lactate is the fluid of choice that you need to give in to this group of patient. Now, again, this patient had a 15% of burn. So, as an ED physician, how will you manage the wound as such? What will be the management of wound that you need to take care in the ED?
So, initial wound care involves removing the clots, the burn clots, and also start the patient on running water. Followed by we had to clean the area, and later we had to apply dressing, which can be either dry sheets, or we can also later in small wounds we can use saline soaked dressings. In large areas we can also use colloid dressing also.
There are a lot of different dressings, sort of dressing have come exploring in the field of burn. So as an ED physician, our primary aim is maintain the sterility. So whatever procedure that you are going to do, you have to do it in a sterile manner. I'm ashamed to say this, ED physicians are worst manager of infection control practices. That is not because hand hygiene is less, using all other things is worse with the ED physician, that we need to definitely improve. But when you are a patient with burns, definitely you need to take care of the sterile precautions 100%, because they can easily get an hospital acute infection, and when you are not doing under sterile precaution, they will get any sort of an infection. So that is the most important point that you need to remember. And coming to the dressing as such, whatever be the type of dressings that you want to use, you can have. There are a lot of concepts. There are even, something called as fish skin dressings are available for burn management. They are using a lot of these things recently. So a lot of exploration has happened. So whatever be the thing, the most important, whichever method that you are going to use it under sterile precaution. So that is the key message that we want to do. And you want to start her on any antibiotics?
Antibiotic, if blood culture positive only, as the recommendation, if blood culture is positive, we have to start on antibiotics.
So that is the present recommendation, but definitely when you are getting in the hospital where you don't have a dedicated burn facility, where a dedicated burn facility, only requirement is that they have to have a sterile area, and the dressing, everyone should be knowing how to do the basic dressings for burn. But if you don't have anything, it's better advisable to start an antibiotic. But blood culture positivity, yes, you need to start on. And maybe pus culture you can also do from whatever be the debridement that you are getting, you can do the dressing. But in general, if you wanted to dispose of a patient from the ED who has got like 5%, you will not, actually it is no need to start on any antibiotics unless and until you feel that they are immunocompromised, like diabetes. There is a chance of infection. Then you can put on some antibiotics, maybe amoxicillin, plain amoxicillin, maybe with clavulanic acid, maybe even azithromycin is a reasonable choice for skin coverage. We wanted to just have a gram-positive coverage. So that is one thing that you need to remember. And IV antibiotic as such, generally not recommended. When you have a sterile dressing, she is otherwise stable. You need to only manage that area very clean. But whenever you are suspecting an infection, that the secondary death, that whatever happens due to the burn is due to secondary infections. So secondary infection prevention is the key. And any role for local applications of this silver sulfadizine or this antibiotic antimicrobial agents?
New studies are showing that there is actually very less or no role for silver sulfadizine.
Actually, whatever you are applying, you are intervening with the wound, and you are giving some material so that an organism can stay back. So silver sulfadizine has got some antibacterial property, but majority of the time the patient requests for some cream. That's why we are recommending this. But maybe a small wound and all you can give, but generally for a larger wound it is not much needed. But mostly the problem what this patient will have is significant pain. So pain you have rightly treated with a higher agent rather than starting from a lower agent. Suppose this patient with 15% burn, she is not complaining of any pain. So what will you suspect?
So patient can have some comorbidity like diabetes. Patient can have
No, the same patient. No comorbidities.
can be because of a deeper degree of burn, third degree or fourth degree burn.
So that is not again a good sign. So when you think the patient is not complaining of any pain, it will have become more and more deeper structures involving your superficial, involving your deep fascia, muscle, as well as the bone. So, and the most important other risk factor is the compartment syndrome. So without discussing compartment syndrome, burn management will not be complete. So what has been done for her? They did a debridement, and you have to frequently look for, especially upper limb and all, lower limb, upper limb, calf area and all, they are very prone to develop anytime compartment syndrome. So compartment syndrome, you need to do sometime fasciotomy, or what we call it as, if there is a larger escharotomy. So we need to remove the total eschar, and eschar needed to be done. So that is again one of the concern. And rhabdomyolysis, hyperkalemia and rhabdomyolysis, not immediately, maybe after 48 to 72 hours. So they are more prone for developing this because there are a lot of muscle enzyme degradation. So they are more prone to develop this rhabdomyolysis and secondary sepsis, rhabdomyolysis, hyperkalemia. So these are the major problems that they will anticipate. Okay, so what happened to this lady?
So initially after removing the whole clothes and cleaning, we started her on IV fluids, and later on we sent for the blood cultures, and later we started her on pain medications. Fourth hourly we were giving her pain medication, and we did debridement for her.
Okay.
Later wound care was done, and later on discharged.
She was discharged. Okay, fine. Anything else that you want to add on with this case?
Then just to, the normal classification of
first degree, second degree. Can you just elaborate for the audience?
So first degree is superficial bends. It will be involving the epidermis only. So we can identify the first degree bends by the red color of the bends. Whereas in second degree, we can divide into superficial partial thickness and deep partial thickness wound. So the superficial will be having blisters, whereas the deep will be also having blisters, where the color will change to yellow to white, whereas superficial partial thickness will have a red color. And the superficial partial thickness wound and deep will be involving the epidermis and dermis, whereas the third degree will be having the subcutaneous tissue, and fourth degree will be having the muscle and the bone. These are the four types of criteria.
Okay, fine. That's it. Okay. You have anything else that you have prepared? Then that we have missed something that you want to add on?
Other thing will be like types of burning, including that thermal, chemical, electrical, lightning wound.
Okay. So acid attack, that is one of the common thing, no? So what should be the first aid for acid attack?
Rapid water, running water.
Running water. So that is again, a lot of misconceptions are neutralizing agents. Should not be never be applied. Which is more dangerous, acid or alkali?
Alkali.
Alkali is more dangerous, so you will never apply any neutralizing agent. Don't apply anything. Just running water is mostly what is required for the cleaning. And later on, you have a lot of advancements like skin grafting, split skin grafting. All those things will come. But as an ED physician, we should be knowing what is the most important thing that I wanted to request everyone is the sterile precautions. Whenever you are managing a wound, any wound for that matter, any patient for that matter, but specifically in burns, the only thing that is going to save her is when you are doing a proper dressing under sterile precautions. Okay, fine. Thank you.